Hello everyone, I'm Dr. Deepika Katyal. I'm an orthodontist and an Invisalign provider. I'm currently working as a senior lecturer in the Department of Orthodontics at Sree Balaji Dental College and Hospital, Chennai. In today's presentation, I will be talking about the twin block appliance, which is a functional appliance used for correction of the anterior-posterior jaw discrepancy in skeletal class 2 patients. In today's presentation, I will be covering about the design of the twin block, its origin, the parts of the twin block, bite registration, its indications and contraindications, and retention therapy. So to begin with, functional appliances are removable or fixed appliances that either utilize, eliminate or guide the forces arising from the muscle function and alter the position of the mandible to produce a combination of both dental and skeletal changes. Like I mentioned before, they are frequently used for correction of anterior-posterior jaw relationship in growing patients with a skeletal class 2 malocclusion. Now coming to the twin block, twin blocks are constructed with a protrusive bite that effectively modify the occlusal inclined plane by means of acrylic planes on the bite blocks. The purpose is to promote protrusive mandibular function for correction of the skeletal class 2 malocclusion. The occlusal inclined plane in the twin block act as a guiding mechanism that causes the mandible to be displaced downward and forward. With the appliance in the mouth, the patient cannot occlude comfortably in the formal distal position and the mandible is encouraged to adapt to a protrusive bite. There is a very interesting story as to how the twin block came into being. So the twin block was developed by a Scottish orthodontist, Dr. William J. Clark, in the year 1977. So it so happened that an 8-year-old patient named Colin Goff fell and completely luxated an upper central incisor tooth. So the upper central incisor that was luxated was stabilized with a splint. So the occlusal relationship was a class 2 division 1 with an overjet of about 9 mm and the lower lip was strapped lingual to the upper incisors. So in order to overcome this kind of a malocclusion, an appliance was designed to reduce the upper jet without applying direct pressure to the upper central incisors. So this is how the twin block came into being. The first appliance was constructed with an inclined plane of 90 degrees with incisal edge to edge relationship and a vertical separation of about 2 mm. The bite blocks proved comfortable to wear and treatment progressed well as the distal occlusion corrected and the overjet reduced from 9 mm to about 4 mm in 9 months. This is how the twin block came into being. Now coming to the mechanism of action of how the twin block acts, it is known as the Pterygoid response theory and this was given by McNamara and Petrovic in the year 1980. So when the mandible is postured downwards and forwards with the appliance being in the mouth, there is an area of cellular activity which develops above and behind the condyle, which is called as the tension zone. This area is invaded by proliferation of blood vessels and bone tissue. And when this happens, a new pattern of muscle activity is established wherein the patient finds it impossible to retract the mandible to its former position. Thereby, the bite of the patient and the profile of the patient is corrected. The mandibular protrusion causes a change also in the muscle of mastication and establishes a new equilibrium in muscle behavior. When the altered muscle function is established, the proprioceptive sensory mechanism initiates compensatory bone remodeling to adapt to the altered function. The muscles are the prime movers in growth, followed by bone remodeling as a secondary response to the altered muscle function. Muscle function must be altered over a sufficient period of time to allow adaptive bone remodeling changes to occur to reposition the condyle in the glenoid fossa. Now let us move to the design of the twin block. So the twin block basically consists of upper and lower plates, bite blocks, an upper midline screw which is optional and can be used only in cases where expansion is required. The wire components are as follows. They consist of labial bow, delta clasps, ball end clasps and C clasps. The delta clasps replace the Adam clasps because they provide more retention and they reduce the metal fatigue. The characteristics closed triangle shape makes sure that the clasp doesn't lose its retention after repeated insertion and removal of the appliance. Later on, Modifications with circular loops were introduced which were easier to construct and did not require adjustments. Like I mentioned earlier, the first twin block that was given to the patient had an inclination angle of 90 degrees. However, this can be a little uncomfortable for the patients and can interfere with mouth opening and closure. Therefore, certain modifications were made to the design of the twin block, where the angle of inclination was reduced from 90 degree to 45 degrees and then subsequently to 70 degrees. So, an angle of 45 degree was found to be more appropriate to guide the mandible forward for the patient. However, a steeper angle of 70 degree, which is currently in use, is more comfortable and helps to lock the mandible in the protruded position and prevent sliding of the mandible back to the previous position. Also, to prevent proclination of lower incisors, an addition of an incisal capping over the incisors can be done. However, no significant proclination has been observed, and sometimes these acrylic cappings can cause decalcification in case the patient has a poor oral hygiene. Now coming to the indications of the twin block. So the major indications of the twin block appliance are class 2 division 1 malocclusion. They can also be given in class 2 division 2 malocclusions, class 1 open bite cases. Herein, the lower appliance is modified to extend to the lower molar region with clasps on the first molar and occlusal rests on the second molars to prevent over eruption. Class 3 cases, a reverse twin block can be used. Positive VTO is an indication wherein if the mandible is brought forward to a class 1 position, the patient's profile improves. Also, it is important to make sure that the dentition does not have a severe crowding before giving a twin block. Contraindications of the twin block appliance include a class 2 skeletal malocclusion where the maxilla is at fault, which means a maxillary prognathism. If the lower incisors are severely inclined, then a twin block is contraindicated. Also, if there is severe crowding present in both the upper and the lower arches, then a twin block is contraindicated. A large gonial angle suggests a vertical growth pattern. While vertical growth patterns are not entirely contraindicated for twin block therapy, functional appliances can be used only as an initial treatment phase, which later have to be treated with other orthopedic or surgical treatments depending upon the extent of the severity of the malocclusion. It is also extremely important to monitor the condylar position during treatment. So, the methods involve recording high quality joint X-ray films at different stages of treatment to track the changes in the condylar position. So, the different stages at which these X-rays can be taken are: the position of the condyle is recorded before treatment with the teeth in contact, the downward and forward position of the condyle in fossa when the twin block is inserted, position of the condyle after the overjet has been reduced, and also the position of the condyle on completion of treatment. It is also important for us to know the difference between two terminologies, which are laterognathia and lateral occlusion, as they form a very important basis for giving the twin block. Lateral occlusion and laterognathia need to be carefully diagnosed and differentiated in the patient at the time of recording of the postural rest position. In lateral occlusion, the center of the mandible and facial midline coincide in rest position, but in occlusion, the mandible deviates due to tooth interferences, leading to a non-coinciding midline. A functional appliance like a twin block can be used to help guide the jaw into a more functional and comfortable position. Whereas in laterognathia, there is a skeletal malalignment where the mandible is positioned laterally, which is not possible to be corrected with a functional appliance such as a twin block, and a surgical intervention might be required. So, to conclude, a lateral occlusion can be managed with a functional appliance, whereas a laterognathia cannot be managed with a twin block and might need surgical intervention. Now coming to bite registration of the twin block. So construction bite is defined as the process by which the position in which the functional appliance has to be processed is registered. To record the construction bite, the mandible should be positioned protruded approximately 3 mm distal to the most protrusive position that the patient can achieve, while vertically the bite is registered within the limit of the freeway space. There are several armamentarium which are required to register the construction bite, which include case sheet, horseshoe shaped wax rim, hot water bath, color pencil, rubber sheet, BP blade, carver, upper and lower models, steel scale, divider, face mirror, articulator and fixator. The X-Acto bite or project bite gauge is used to record the protrusive interocclusal record for the construction of a twin block. Also, the George bite gauge has a millimeter gauge to measure the protrusive path of the mandible and determine accurately the amount of activation registered in the construction bite. So, whenever a construction bite is being recorded, the activation of protrusion should be within the masticatory muscle physiological limit and the ligament attachment limit. So, the total protrusive movement is equal to the overjet in centric occlusion minus the maximum protrusion possible. Therefore, in a twin block, the amount of protrusion that we achieve while recording the bite should not be more than 70% of the maximum protrusive limit of the patient. If the overjet is greater than 10 mm, then an initial activation of about 7 to 8 mm should be done, followed by subsequent activations in later stages, and the vertical dimension should always be within a range of 4 to 5 mm in the first premolar region. Now coming to the stages of treatment of twin block. So once the twin block has been delivered to the patient, there are various stages in treatment, the first stage being the active phase. So in the active phase, the patient is advised to wear the twin block full time. The objectives are to correct the anterior-posterior as well as the vertical and transverse dimensions. The overjet and overbite are expected to be corrected within a period of 6 months, and the lower molars begin to erupt into occlusion within 9 months. So a total duration of wear of the twin block is about 6 to 9 months. Coming to stage 2, which is known as the support phase. In the second phase of treatment, an anterior inclined plane is introduced into the patient's mouth, which has an upper removable appliance fitted with an anterior inclined plane to engage the lower incisors and canine, and the patient is instructed to wear this appliance full time. The objective of this phase is to retain the corrected incisor relationship until buccal segment occlusion is fully established. The lower twin block appliance is left out and the posterior bite blocks are removed for the posterior teeth to erupt. The reason why we ask the patient to wear it full time is to allow for the internal bony remodeling to take place, and also it provides excellent stability even after twin block therapy. It is important to note that the support phase of treatment is as important as the active phase. Instructions to the patients are of paramount importance. So whenever the patient is in their active and support phase, there are a few instructions that we must give to them. The first one being patient motivation. It must be a protocol to provide instructions that motivate the patient, and demonstration in models is mandatory. We must explain to the patient the role of the inclined plane in correcting the bite. The improvement in facial appearance soon after wearing the appliance is also a very important motivating factor for the patient. The patient is then taught how to insert, remove and wear the appliance, and in case there is an expansion screw, how to operate the expansion screw. The patient is instructed to wear it during meal and also while biting, since the appliance works better with the forces of occlusion. The patient is advised to only remove the appliance while cleaning. Clinical management in active phase. So during the first visit, the twin block is fitted, and we must make sure that the lingual flange is relieved slightly lingual to the lower incisors, and the clasps are adjusted properly without any gingival impingement. Labial bow, if present, must be out of contact with the upper incisors. Selected cases benefit by bonding the appliance for first 10 to 14 days, but the clinician must check for the comfort of the patient during the protrusive bite. The second visit of the patient is after 10 days. So in this appointment, if there was any initial discomfort that the patient faced, it needs to be resolved, and a comfortable forward bite while eating is usually established. If the patient is failing to posture the forward bite consistently, the clinician must consider reducing the activation by trimming the inclined plane slightly. The patient should turn the screw of activation if an expansion screw is present under supervision. In this stage, only minimal adjustments to the appliances should be made, and in case of any difficulty, reassurance to the patient should be provided. In the second visit, we must also look at the overbite correction. So in cases with a deep overbite, the bite blocks should be trimmed occlusodistally to relieve 1 mm for the molars to erupt and increase the lower facial height of the patient, which will further reduce the overbite. In case the patient presented with a deep bite or a reduced overbite, the bite blocks should not be trimmed and all posterior teeth must be in contact with the blocks to prevent posterior teeth eruption. The third appointment is usually after 4 weeks, and at each visit we make sure that the overjet is measured and the occlusion is checked for correction of buccal segment relationships. Progressive progress of the facial muscle balance should also be made a note of. Minor adjustments are made like keeping the labial bow out of contact from the upper incisors and adjusting the clasps if necessary. Checking whether the screw is operating properly and ensuring the lower molars are not in contact with the upper blocks is very important in case of a deep overbite. The fourth visit is usually after 6 weeks, and a similar pattern of checking for overjet and occlusion is carried out, and in case any adjustments are needed, they are also carried out. The upper arch must not be overexpanded into crossbite. So it is important for the clinician to make sure that the expansion is sufficient enough such that both the upper and the lower arches are well coordinated. William Clark holds that clinical management is simplified by introducing a single large activation provided that the growth is favorable for functional correction. Progressive mandibular advancement is beneficial when growth is less favorable or when vertical growth is more. Now coming to the advantages of the twin block appliance, a major advantage of the twin block appliance is that it can be worn full time. A full time wear enables the patient to adapt completely to the appliance such that light continuous forces are provided continuously and that enables maximum correction of the skeletal discrepancy. Another major advantage of the twin block appliance is that it causes very less interference with normal function and the mandible is free to move in anterior as well as lateral exertion. Patients usually quickly learn to speak normally with the twin block appliance and the appearance is noticeably improved when the twin blocks are fitted, and this acts as a major motivating factor for the patients. The twin blocks can also be designed with no visible anterior components. This enables the patient to have a better aesthetic view. The appliance also comes with a few disadvantages. Number one being that the appliance is completely patient dependent. The compliance of the patient is paramount for the appliance to work. Sometimes speech and comfort could be challenging, and some patients may experience temporary difficulties with speech, especially during the initial adjustment period. There is always a risk of lower incisor proclination with twin block therapy, which may lead to aesthetic concerns and potential periodontal issues if they are not monitored and managed appropriately. There is also a potential for posterior open bite. There is a risk of developing a posterior open bite during treatment, which may lead to an unsupported TMJ after treatment. Coming to the clinical outcomes, so the expected clinical outcomes after a successful treatment with twin block is that the overjet decreases, the overbite also decreases, the SNA angle decreases, the SNB angle increases, the ANB angle decreases, the mandibular plane angle increases, and the occlusal plane angle decreases. As a result, there is also a decrease in the interincisal angle, the lower facial height increases, and the facial profile of the patient improves drastically. Coming to the last part of this topic, which is retention therapy. Retention therapy after twin block appliance treatment is crucial to maintain the achieved correction and prevent relapse. There is always some rebound potential following removal of the twin block appliance. It is therefore recommended that an upper removable appliance with a steep and deep anterior bite plane is provided to help the patient maintain the achieved result, whereas they can also progress into fixed appliance therapy simultaneously. So this anterior inclined plane is constructed just behind the upper incisors and canines, and it tilts lingually at an angle of about 70 to 80 degrees to the occlusal plane. The inclined plane should be sufficiently steep and deep to prevent the patient just biting on the tip of the bite plane. By promoting forward mandibular growth, the inclined plane can help correct the class 2 relationship, whereas the upper jaw is positioned forward to the lower jaw. The advantages of this retention appliance is that it reduces the amount of time which would eventually be required for settling of occlusion using fixed appliances. The second advantage is that it can be used in conjugation with fixed appliances and during the settling phase of post-surgical orthodontic treatment of class 2 division 1 malocclusions. It is simple and easy to fabricate, and it can be removed easily by the patients for maintenance of cleanliness. The disadvantages, however, are that it is a removable appliance, therefore patient compliance is necessary. It can be a little difficult for the patient to adapt to normal function of speech with large tongue sizes and protracted resting tongue posture. There is also an increased risk of damage or breakage of the appliance if it is not worn or handled properly. These clip-over bite planes are used until the patient is on a working arch wire, which is usually upper and lower 1925 stainless steel, and at which stage class 2 elastics can be placed. So once the patient starts with class 2 elastics, the steep and deep appliance can be removed. The clip-over bite plane is discontinued after usage of elastics, like I mentioned. An alternative form of retention is to use the twin block on night-only basis for 3 to 6 months. A quick recap of what we saw in today's video, starting with the introduction and origin of the twin block appliance. I also discussed the various components and parts of the appliance. We spoke about the indications and contraindications of twin block therapy. We also spoke about how to take a construction bite, then followed by the various phases of treatment, and finally finishing up with the retention phase. So that brings me to the end of this video, and I will be back soon with another lecture.